Good morning, everyone. I'm happy to talk about the efficacy of repeated immunoadsorption in post-COVID ME/CFS. I think most of you have seen most of the data already because it was published last year and we talked about it in several conferences already. Nevertheless, it's the basis for further studies that we are conducting, so I'll sum up quickly, and I hope I'll... The green one, okay. This was an intelligence test. So we've heard a lot about the G protein-coupled receptor autoantibodies, and in pre-pandemic times we already found that they are natural regulatory autoantibodies. We picked the beta-2 adrenergic receptor autoantibody and we saw an impaired function in ME/CFS. We saw also elevated levels and a correlation of elevated beta-2 adrenergic receptor antibody levels with symptom severity in ME/CFS. This was already mentioned in several talks before. And we observed in clinical trials targeting autoantibodies that they provide an evidence in efficacy in ME/CFS. So these are the two trials conducted in 2018 and 2020, where we applied immunoadsorption on patients with ME/CFS, and we saw an effect. So based on these findings in pre-pandemic times, and also based on the findings and studies in post-COVID and autoimmunity, we conducted this observational study on immunoadsorption in post-COVID ME/CFS. We picked 20 patients with post-COVID ME/CFS, fulfilling the Canadian criteria, and elevated beta-2 antibody levels. Out of these 20 patients, we had 13 female and 7 male patients. The age was in median 40 years and the duration of illness 22 months. Bell score was between 30 and 40. And we conducted 5 sessions of immunoadsorption within 10 days in an outpatient setting. And responders received a second cycle after worsening of symptoms, which was in between 6 and 10 months, roughly. The primary endpoint was the improvement of at least 10 points in the short form 36 physical function 4 weeks after immunoadsorption. We also applied further surveys, the COMPASS, the FSS, Bell Scala, the PEM Scala, and we measured the hand grip strength and the endopet. So here in the slides above, you see the curves of immunoglobulins, and we could see a significant reduction in IgG, IgM, and IgA after 4 weeks after the immunoadsorption, and then in the course they normalized again. And in the slides lower, you see the curves of the autoantibody levels. So in all 4 autoantibodies that we measured, the beta-1, beta-2 adrenergic receptor antibody, and the muscarinic, the M3 and M4. So you see 4 weeks after the immunoadsorption, you see a significant lowering, and then after a normalization. And in the talk before, for Judith Bellman-Strobel, there was the question of how you know that the IgG levels were not affected by the immunoadsorption. And here you see that they will normalize again. And then after normalization, you will apply further medication. Here you see the course of symptoms. So we see an improvement in SF60. SF36 after immunoadsorption, and a little bit lowering after 6 months. In the responders, this is more obvious, of course, and in the non-responders, you didn't see this significant improvement. Then we picked further symptoms. For example, in the PEM, you also see an improvement of PEM after 4 weeks, a worsening then in the following month. And in the pain score, for example, also we could see this significant improvement. And here in the slides on the left side, you see the first cycle, so the improvement and the worsening after month 6. And on the right side, you see the second cycle. So again, we have an improvement after the immunoadsorption, very clear after 4 weeks. And then in the course of 12-month follow-up, we didn't see a long-lasting effect. So the conclusion is that we see immunoadsorption, and hereby lowering of the autoantibodies, is effective in patients with post-COVID fulfilling ME-CFS criteria and elevated beta-2 adrenergic autoantibodies. But we also see that there is no long-lasting effect of repeated immunoadsorption. This leads us to the question, what is the role of immunoadsorption in further treatment of ME-CFS? Herefore, we are still waiting for the results of a RCT, which is currently taking place in Berlin in the Department of Neurology of Harald Prüss. But we know already there's limited availability and limited efficacy, so this will not be the only possible treatment for ME-CFS. But what we already heard from Judith Ballmann-Strobel, that in combination with CD19 or CD20 monoclonal antibodies, depleting the autoantibody-producing B cells, there might be hope for a long-lasting effect in treatment. And last but not least, we are still looking for causes why some people responded and some people were non-responders, and therefore the B-cell subtyping, where Birgit Sawicki told us yesterday, or showed us yesterday, the super interesting results, there might be one reason for responding versus non-responding. Also, we are measuring further autoantibodies and further markers for immune dysregulation. So all of this wouldn't have been possible without the amazing team of the Institute for Immunology of the Charité. Thank you very much.
Thank you very much, Elisa. Professor Scheinenborgen asked us to see if there are interesting questions from the public. There are many, and most probably they will be taken care of on the website, etc. But there is one note here that I would like to read it, and you to respond to her and to other patients. And it is, I'm really unhappy always healthy positive results of the immunoadsorption. I crashed to Bell 0 afterwards and know a whole of fellow patients whom happened the same. You have to address it and to convince her to come for the therapy. Please.
No, but this is something we saw a lot, especially in patients with a low Bell score, that if there's a certain line, if you're below this line with your physical status or your physical function status, then the whole procedure of immunoadsorption is very, very exhausting. Like you go there, especially because we did it in an outpatient setting, so the people had to get there. Some of them had to use public transport. They had the whole, the people they didn't know, the atmosphere they didn't know, the whole procedure of the puncturing of the veins and so on, and then going back, then having 1 day at home, then going back there. So it's not the immunoadsorption itself that leads to a worsening or to a crash, it's the whole procedure around it. So this we have to have in mind, that with people with a very low, but we'll have another talk about immunoadsorption in severely ill patients. So what we saw is that up on a certain level of, let's call it fitness, this whole procedure is bearable. And we shouldn't be very careful, or we should be very careful of applying immunoadsorption in people who are patients that are not, that are below this line.
So can I add it to your?
Yes.
answer that nothing is 100% positive, and there is big individual differences between patients, and we have to select them better a priori to exclude those that we predict that will not actually respond to one therapy or another. So is there any question to Elisa, please? Yes, please.
With this procedure, you remove proteins and you lower the oncotic pressure to worsen orthostatic dysfunction. Do you replace proteins, albumin or IgG?
Yeah, this is a question we discussed also because we saw it in some of the patients, and no, we did not. We did not do it in general. We tried in some of the patients where we selected, but we didn't have a better outcome. I think it's something needs to be discussed and tried out. But in general, that was well tolerated, and the people did not show a significant worsening of orthostatic symptoms.
Thank you very much, Elisa, and we will have another lecture on immunosuppression.